I want to put that link into the Canvas for you guys. Okay, so what we're going to do is we're just going to review fluids, electrolytes just a little bit, since this will help supplement your reading. So let's just make sure we're okay on our normal values. So first of all, what are our, if this is a cell here, okay, so I have intracellular and I have extracellular, all right, I have intra and extracellular. Let's talk about the major cations and anions. Okay, what are cations, first of all? Cations. What are they? They're what kind of charge though? Positively charged, right? And then you have anions, and they are negatively charged, okay? And cations and anions collectively are known as what? There you go, electrolytes. All right, of which you have two flavors, cations and anions, okay? Electrolytes, or you could also call these ions, anything that's charged. All right, cool. So what are your major extracellular ions? Guess around this.
Sodium.
Sodium, yeah. Sodium is your major extracellular. How about intracellular? Potassium. All right. Are there some other major electrolytes or ions that we have in the body?
Calcium.
Calcium, yes. Now, calcium has a +2 charge. Okay, so it's a little different than sodium and potassium that have a +1. Calcium's a +2 charge, so it is actually lost 2 electrons. What else? It's our major negative charge. Huh? Chloride, right? All right, what else? Magnesium, yeah. And magnesium is also a +2 charge as well, okay? All right, we have some other minor ones like phosphate and okay, but these are the major players, okay? Let's review the normal. What are our normal values for sodium?
Sodium.
You'll want to know this.
Milliliters or milliequivalents?
Yeah, they are measured. Yeah, anything charged, right, is measured in milliequivalents per liter.
It's
45.
Say it again.
45?
No, not quite.
35 to 1.
There you go. 135 to 145 milliequivalents per liter. You guys got that? All right. If it's less than 135, what is the name of the condition? It is hypo something. Natremia, right? All right. If it is greater than 145, we call it hypernatremia. All right. And what is the normal potassium level in the body?
3.5.
There we go. 3.5 to 5 milliequivalents per liter. Less than 3.5 is indicated is what? Hypokalemia. All right. Greater than 5 is All right. This should be nothing new. Hopefully this is nothing new. It's just some review. Okay. Cool. All right. And then chloride. You don't really have to memorize. It's right around 100, 110 for normal chloride. But you also have hypo and hyperchloridemia, and hypo and hypermagnesemia, and hypo and hypercalcemia as well. We'll kind of focus on sodium and potassium here. All right. You guys good with that? Everyone's cool with that? Okay, cool. So when I become hyponatremic, in a hyponatremic situation, where I have low sodium in the body, what's the major concern here?
Sodium.
Okay, yeah, not enough sodium, yeah. Okay, that's the axiom, that's a kind of self-evident. Okay, let's draw a cell. Let's picture this, alright? Here I have a cell, right? I have a cell with some sodium and potassium and other stuff dissolved in it, alright? And I'm going to put that cell into an environment where there is not a whole lot of sodium. Okay, a hyponatremic environment. Everyone's good with that? In this hyponatremic environment, what have I done to the tonicity? What is the tonicity of this hyponatremic environment? It is what?
Sodium, water.
Hypotonic, right? Hypotonic. This is a hypotonic situation. So what's going to happen in this hypotonic situation? Where is the water going to go? Water is going to move into the cells, right? And then the cells are going to swell. Okay, we're going to have swelling of the cells in hyponatremia. Where do you think that is the biggest concern?
It's gonna swell.
Where's cellular swelling a biggest concern in our body? Why the brain? What's significant about the brain swelling? Why though? Why is that what's going on there? It's there's nothing complicated about it. If you just think about it, well,
There's no room for it.
there you go. It doesn't have anywhere to go. Your brain doesn't have anywhere to go. So your brain starts swelling and it doesn't have anywhere to go. That's a bad news. And just like somebody mentioned, your intracranial pressure is going to go way up. So the big problem with hyponatremia is cerebral edema. Okay, that is a big problem with hyponatremia. Cerebral edema, swelling of the brain. Okay, and these patients could be prone to having seizures and all sorts of problems. You can have a couple of different flavors of hyponatremia. You can have a flavor of hyponatremia where you are actually losing sodium. Okay, you have sodium loss. You sweat it out possibly, you pee it out, whatever the case may be. You have an actual loss of sodium ions. The other type of hyponatremia that we run into is something known as dilutional hyponatremia. That is where the sodium in your body becomes diluted out. Okay, a classic example of this might be water toxicity. Okay, if I drink copious amounts of water in a short amount of time, that might be enough to dilute out the sodium. There are some endocrine disorders that you guys will talk about in your medical block, particularly a disorder known as SIADH, syndrome of inappropriate antidiuretic hormone, where your pituitary releases too much antidiuretic hormone, and that causes your body to hold on to water, and that, of course, can create a dilutional hyponatremia. You guys are probably all familiar with, or you've heard about one of the drugs of use and abuse of ecstasy, or MDMA. MDMA can make people very thirsty. They drink lots of water, and MDMA can also alter pituitary hormones where they act on the kidneys, cause them to hold on to water. Okay, so a big deal there. When we talk about managing hyponatremia, seizures is going to be something big, and we're going to have to do sodium correction. Now, I'm not going to hold you guys accountable because this is respiratory, so we're focusing on respiratory stuff, but fluids and electrolytes kind of flow naturally in the respiratory discussion. But you're going to have to look at sodium replacement, possibly even administering hypertonic saline, like 3% saline, and slowly correcting the sodium levels. Something that's done very, very slowly. Okay, hypernatremia. Okay, hypernatremia is kind of the opposite of that, where you place the cell into a hypertonic environment. In what way is the water going to go?
Go out.
Yeah, so you're going to have shrinking of the cells, crenation of your cells, which of course is going to cause intracellular dehydration. Okay. I'm not going to talk too much more about hyper and hypokalemia because we talked about this in ECG interpretation because I had a lecture on the cardiotoxic stuff, and this is something that came up. You guys remember talking about particularly hyperkalemia. We talk about all the things that can cause hyperkalemia, renal failure, crush injuries, major burns, certain drugs like administering succinylcholine, things like that. So hyperkalemia, hypokalemia. So the kind of the big rule of thumb is your sodium is going to affect your brain. Your sodium imbalances are going to affect your brain, and your potassium balances often going to affect your heart. All right. You guys good with that? Calcium imbalances will be important in your med block particularly when you talk about parathyroid disorders, because your parathyroid hormones are very important in regulating calcium in the body. And this is a situation where muscles, skeletal muscle, are often affected. So you have brain, heart, skeletal muscles affected. You guys good with that? Okay. I know that's a really, really down and dirty overview of the some of the major electrolyte issues we run into, but I wanted to just kind of cover those to make sure everybody's on the same page. You definitely are going to want to know your normal values for sodium, normal values for potassium. Okay, you definitely want to know those. All right. So what I'm going to do, we'll talk for a few minutes. What I'm going to do here is I'm going to go back to ABGs a little bit. And I'm going to add just one more layer of complexity onto the ABG interpretation. Sorry, I know you guys probably thought, finally got through that ABG stuff, right? So there's going to be one more layer of complexity. And that is when you identify the presence of a metabolic acidosis. All right, yes. If it's compensated, uncompensated, or partially compensated, if there is a presence of a metabolic acidosis on the ABG, what you need to do is you need to realize that there are different forms of metabolic acidosis. Okay? And the two major ones are what we call non-anion gap acidosis and then anion gap acidosis, or elevated anion gap acidosis. Okay, you guys cool with that? Do you kind of remember seeing those words when you were trying to read that fluid electrolyte book? No, most of you guys are shaking your head because probably most of you guys didn't read
I think it's
all
so
of them.
boring.
Oh, it's not that boring.
It's boring, Chris.
Okay, it's pretty
I'm
boring.
going, it's just kind of hard to understand.
It was hard to focus. Like, I made it through, but it was like, I don't remember.
EMS types, I swear. Your attention span. You need like little pictures of cows and stuff.
We
like
really
that.
do.
Yeah.
I mean, it's really important to have those things.
Hence the reason that I'm kind of talking a little bit about this stuff. Even though we're not directly running into this in respiratory, when you guys hit med block, this acid-base stuff kind of comes back a little bit to haunt you. So I just want to make sure that you guys have got the big stuff down. Okay, so what in the heck is the anion gap?
It's okay.
Wow. Okay. So broadly speaking, it's some sort of gap. Great. Let's narrow in on what that means.
Production of endogenous acid,
No.
exogenous complex.
Let's talk about what it is. To understand the anion gap, you have to understand the principle of the electroneutrality. What a big word that is, huh? Electroneutrality. And the principle of electroneutrality says that for every positively charged particle I have in my body, it should have a mate somewhere. It should have a negatively charged mate. Okay? So if I were to look at the human body, and if I were to take all the positive charges, all the cations, okay, all the cations in your body, okay, there should be an equivalent number of anions to balance out the positive charge. The positives and negatives should basically balance out, and the human body should not have a net charge on it unless it's being electrocuted and there are lots of electrons moving into it, right? But that's a pretty bad situation. Under normal circumstances, cations equal anions, okay? Does that make sense? And the difference between cations, okay, all the positive charges. So if I take the positive charges, and I'm going to put a really scary looking symbol up here. Ooh, scary symbol. That's a sigma, okay? That's just old Greek alphabet. Sigma just means to add everything up, just means to take a sum. Anyone here taking statistics? Right? And you remember pulling up your spreadsheet and you hit the little, that's all it means. It just means add them all up, okay? So if I take the sum of all of the cations, all right, all the positively charged things, whatever that number is, I subtract the sum, okay, the sum of all of the anions, okay, I should more or less get 0. Does that make sense? They should more or less equal out. All right? Now, that's the gap. The gap, the anion gap, is the difference between cations and anions. You subtract the anions from the cations. And whatever this number is right here, this is the gap. Does that make sense? Now, we realize that it's really hard to measure everything exactly, so we have a range. We say right around 8 to 12 milliequivalents per liter is what's considered a fairly normal gap. Okay, so there is a normal gap, but it's still pretty small, about 8 to 12. Some people may even go as high as 16. But if you have a metabolic acidosis and you have something that's higher than 12, you really need to be thinking, okay, this is an elevated gap. Is everybody cool with that? So how in the heck do I calculate it? Okay, well, we can take all the positives. What do you guys think? Does that sound like a practical thing to do? So I gotta find all the calcium, all the magnesium, all of the potassium, all the, oh yeah, hey, there's a formula. Or can I just take the major players? Yes. So what we do is we take, who are my major cations? Sodium and potassium, all right? So I'm just going to look at those two. I know that there's some magnesium. I know that there's some calcium, right? And that's what goes into this here, this 8 to 12, that little difference is okay, that's the magnesium and the calcium and all the other positively charged ions that I just don't care about all that much. That's that difference there. But the major players are sodium and potassium. Those are my major cations. Who are my major anions? Chloride and calcium's not an anion. Kelly? Magnesium's not an anion either. You got the formula right there, right?
Yeah, but I don't know what they mean.
Okay.
Bicarbonate?
Huh? Bicarbonate, there you go. Bicarbonate. HCO3 negative. Those are your major negative players, right there, all right? So what I do is I take my major players. So let's just say that I run labs on my patient and I have a sodium of 140, potassium of 4, a chloride of 110, and a bicarbonate of 24. All right? And we're going to calculate the anion gap in this patient. So what I'm going to do is I'm going to take my sodium. What's my sodium? 140. Sodium plus potassium 4. All right, that gives me 144. So that's what I have over here on this side. And then I'm going to go to my anions. What's my chloride? 110. And what is my bicarb? 24. So it's 110 plus 24. 134. All right. So then what I'm going to do is I'm going to take 144, right, the sum of all the cations, subtract the sum of all the anions, 134, and what does that give me? 10. That gives me an anion gap of 10. Is that high or normal? It's normal. It's between that 8 to 12 range. So we would say that this particular patient has a normal anion gap. Their anion gap is not elevated. Does that make sense? You guys cool with that? Is a non-elevated anion gap. Okay, cool. So now, are we clear on how we calculate it? Is everybody clear on how it's calculated? It's not that hard. It's not that hard. It's pretty easy to calculate. So, now I'm going to ask the question, why do we care about calculating it? Well, that's a bit more tricky. That's a bit trickier. But let me see if I can. Okay, so here I've got my cells. All right, got my cells here. And normally when I get very acidotic, so I have lots of hydrogen ions, hydronium ions, protons, whatever you want to call them. All right? Okay. I am going to have an interesting phenomena that occurs. First of all, some of the hydrogen is going to shift into the cells. Okay. Some of the hydrogen will kind of shift into the cells as it gets buffered, and some potassium will shift out of the cells. Okay. So in acidotic patients, it's not uncommon to see hyperkalemia. Patients that are really acidotic get a little hyperkalemic because potassium will shift out of the cells. Another thing that can happen is as I am adding hydrogen ions to the mix here. Hydrogen ions are, what kind of charge are they? They're positively charged. What's going to happen is, remember the principle of electroneutrality, right? There has to be some negative to balance out the positive. Well, what will often happen is chloride is going to shift out of the cells to meet those hydrogens. Okay? That's known as the chloride shift. The chloride shift. All right? You guys good with that? So the chloride will actually get elevated a little bit. Okay? Chloride will shift out. In that situation, you may hear the term hyperchloremic acidosis. Hyperchloremic acidosis is associated with a non-anion gap acidosis, this chloride shift. But let's say that there's a mystery substance in your body. Okay? Let's say there's a mystery substance in your body that produces both acids and negatively charged particles. So let's say that the cause of my acidosis is lactic acid. All right? You guys go with that? And lactic acid is going to break down into its acid form, and then something called lactate. which is negatively charged. Now, do I need to have that chloride shift occurring anymore because I have the negative right there to balance out the positive? Do I really need a chloride shift? I don't. And it is this mystery substance, in this case it's lactic acid, is this mystery substance that is inhibiting that shift. And we will see that in the anion gap. Okay? We'll see that in the anion gap. And what will happen is that mystery substance will cause an elevation in the anion gap. Okay? So, if you have a metabolic acidosis, you calculate the anion gap. If the anion gap is greater than 12, greater than 16, you have an elevated anion gap and you need to search for that mystery substance. Okay? And there is a mnemonic called mud piles. That can help us memorize some of the most common mystery meats, if you will, mystery substances. Okay, so M stands for methanol. Methanol is also known as wood alcohol. It's a very toxic type of alcohol. All right, U stands for uremia. What is uremia? What does that mean? Okay, well, literally means urine in the blood. Yeah, so it's a renal failure, right? Uremia. D stands for diabetic ketoacidosis. You guys good with that? P is kind of a rare thing now. It stands for paraldehyde. It's a preservative. I stands for INH, isoniazide, which is a tuberculosis drug. L stands for lactic acidosis. E stands for ethylene glycol. Okay, which is a common, it's a toxic alcohol. It's common in radiator fluid. And then S stands for salicylates. Okay, of which aspirin is probably the most most well known of the salicylates. Okay, so these are some of the more common things that cause an elevated anion gap acidosis. So if you identify metabolic acidosis, calculate the anion gap. If it's elevated, you need to start running through this list of things and go, okay, you might be able to catch something. Maybe the history is this patient, was out with some friends and having a good time, and now he or she is really acidotic, and they have an elevated anion gap. So what does that tell you? Oh, were they drinking something? Oh yeah, they were. Okay. What were they drinking? Did it contain methanol or did it contain ethylene glycol, right? Or was this an overdose patient? Oh, well, did they overdose on salicylates? Let's get an aspirin level, see if it's elevated. Or boy, we better check the blood sugar and rule out diabetic ketoacidosis, or let's run labs and check their BU and creatinine and make sure that they're not in renal failure. This can really help us identify problems. All right. Alrighty, guys? You good with that? Get out of here. Take a break.